My aunt was diagnosed with lung cancer 3 years after I was, and it was actually one of the toxicities of her medication that really kind of did her in. I'm not going to lie to you. I knew things could get bad, but I saw some stuff that I was like, wow. And as a patient, I was just like, I don't know how I would deal with that. Hard because then you get the, oh, you don't look sick. And then because you don't look sick, people will potentially forget. And then they hold you to a standard of normal that you can't maintain because you're no longer normal.
Targeted therapies have transformed what's possible for people with ALK and other forms of lung cancer, allowing many of us to live full and meaningful lives. But these treatments are not without a cost. Side effects can accumulate or be challenging to manage, whether we're new or been on multiple lines of treatment. At ASCO 2026, where 40,000 multidisciplinary professionals gather each year in Chicago, Dr. Sydney Barnett, a physician, an ALK-positive lung cancer patient and patient advocate, spoke on this very topic. Her presentation was called "When Does the Acceptable Become Unacceptable?" Here she shares her takeaways for doctors and patients. My name is Yvonne Diaz. I'm a board member of ALK-positive. I'm also a co-founder of Oncogene Cancer Research, where I live in the UK, and I'm a fellow ALK-positive lung cancer patient. So let's get straight to it. Sydney, welcome.
Hi, everyone. As Yvonne says, my name is Sydney Barnett. I am a physician and a patient living with stage 4 lung cancer. I was diagnosed in my intern year, so I was pretty much learning how to be a physician and a patient at the same time. So I tend to bounce between both sides and I try to make it easier for both sides to understand each other.
That is quite an interesting position you're in, being able to see things from both vantage points. And I'm sure it must also make you a better physician and also a better patient and patient advocate in many ways because you have that unique knowledge in that intersection there.
Yeah, we all try to be as good physicians as possible. Of course, I'm not going to say I'm perfect. But I do think that there have been a lot of times where my patient perspective has definitely come into play to help me be a better doctor.
That's amazing. So you were invited to ASCO to speak on a topic that is really important to us. We are so fortunate in many ways as lung cancer patients. While no one wants this disease, obviously, we do have so much better treatments, right? Many of us are living longer, living well with lung cancer, yet there is a flip side, the toxicities, right? All these treatments do not come without issues in different ways. And sometimes there can be an accumulation of toxicities that come from being on multiple treatments. So why don't you tell us what inspired you to get involved on this topic?
Well, the funny thing about it is toxicities have been something that has always been important to me, not only as a patient, but my aunt was diagnosed with lung cancer 3 years after I was. And it was actually one of the toxicities of her medication that really kind of did her in. So it's kind of dealing with the fact that, yes, these medications are controlling the disease, prolonging our lives, and we're definitely grateful for that. But with more long term survivors now, we're now dealing with the side effects of these treatments longer and more persistently. And that's where it really now comes into when is acceptable, unacceptable, because it differs from what a physician will see and what a patient feels.
Sydney, that's so interesting and such valid points there. So why don't you take us into this topic? What did you find? What was most interesting in terms of your work here?
So, what I found interesting about it is some of the things that I did as a physician patient. You would think that, okay, as a physician, I should be the ideal patient. Actually, to be honest with you, they say this all the time. Physicians and nurses are the worst patients because we try to do a lot of self management, a lot of self diagnosis. So we don't really report a lot. And that's actually one of the things that my presentation actually brought up that even well intentioned patients, such as myself, other patients do it as well, where they don't report because they're afraid of like medication being reduced or even interrupted. And what does that mean for their cancer? So they try to self manage and they try to do different things to try to hopefully help improve the issue. And they go through a lot of emotional turmoil about how am I going to deal with it. And it gets to a point where, okay, this is not sustainable enough. So they either decide to report it, fully disclose it, two, probably will report it but minimize it because they don't want to sound like they're complaining because they're grateful for the medications, or they silently not adhere to the regimen to try to self manage. And it's about trying to let both physicians and patients know one, it's okay to report things early, report things when it's interfering with your life. And for physicians, grading something as mild, moderate, or severe is very trivial when, for instance, I had mild fatigue because I'm still able to work, I'm still able to get up, I'm still able to travel, work out, but the fatigue was interfering with my life. It took me eternity to finish my notes because I literally felt like at 3 p.m., my brain would turn off. And then I'm now struggling to finish my notes because my brain is not firing on cylinders. And that interferes with my life. That interferes with the time I have with my family and friends. That interferes with all of the things. But because it's mild, you don't think that it's as severe to report it, but it's
Mhm.
interfering with your life. And that is one of the things that I wanted patients and physicians to know. Patients, when it's interfering with your life, talk to your doctor about it. Physicians, ask functional questions, not, oh, is it mild, moderate, or severe? Ask, what is this interfering with? And then that can give you a true description of, on paper, it's mild, but this is interfering with her daily life.
You brought up so many important different topics there. And one of the things that also struck out at me is the self-management and the underreporting. I guess two things really. So the underreporting is a problem because people do have fear, right? We're all afraid of being removed off of our treatment. And I think I saw in your presentation somewhere that people believe that side effects are a part. I just have to kind of suck it up. So when it comes to self-management as well, you really need your physician involved, don't you? Because there is a risk that people might try and research on the internet or ask a friend, ask in a support group. And those are all great for, I guess, crowdsourcing ideas. But what is your advice here in terms of how you deal with this?
Think also it has to be where the physician makes the patient feel safe enough to report, because a lot of in my presentation that was also a thing that was I mentioned, in the fact that some patients will feel like they were minimized or dismissed, so because of that they don't report earlier because they feel like that's what one of the responses that they're going to get. So it's about both the physician making the patient feel like it's safe enough to report to me. Don't think anything is too trivial. I'll be the one to sift out the information from that. And two, the patient feeling that they trust their physician enough to be like, hey, this may be trivial, but this is interfering with what I have to do and I don't really like it. So, how can I get help with it?
Right. That's so interesting. I saw also in your presentation you talked about non adherence, which I guess can be another risk if people try and say, I'll just take my own little holiday away from my treatment. What did you hear and see on this?
So, non adherence is more common than we think. A lot of patients will silently say, especially like, for instance, some of our TKI drugs cause fatigue. Don't feel like taking it today, or I'm so tired and exhausted already. Let me take a break today. Maybe I'll pick it up tomorrow. Or even what is more common is patients will dose reduce. So instead of taking the 4 pills, they take 3 pills, saying, okay, you know what? I'm going to take something, but if I take too much, then it's going to make me too tired. It's just like, for instance, a patient who needs to take a diuretic. I hear this all the time in the hospital. They have to take a diuretic twice a day, but they have to run errands on the road. So they hold their diuretic
Right.
and until later on in the day so that they can run their errands and don't have to be rushing and trying to figure out where a bathroom is to pee. patients have to do adjustments all the time. And it's going to be unrealistic for us to not think that patients will do it for certain medications, but it shouldn't be the case that they're doing it all the time. Then clearly there is an issue there.
Gosh, that's so important. It depends on someone's job and their life and their obligations, managing these things.
I mean, for instance, for me, when I progressed, I was offered two drugs, and one drug, which is the better drug, I felt would interfere more with my life the way I wanted my life to be. And at that point in time, I felt like I didn't need to go that strong. And I decided for the side effect profile and for my profile of my cancer, I did not want to deal with that side effect profile. And some people may think that's ridiculous because the other drug is a better drug. And I fully, wholeheartedly agree with that. But for me, and everybody is different, for me, I felt that I could, one, do the other drug much better and be able to have my cancer controlled, live my life with less interference, be able to work, and all of these things that are important to who I am as a person. And while I am fortunate enough to be able to make that decision for myself, not every patient is able to make that decision. So, as a physician, you need to be the one to give them the insight that is needed.
It is incredible. And that's such an important and a bit of a brave move, right? We want to live, but we want to live well. It's important to work. You need to work. You studied to work. You should work, right? You were in the middle of your internship. And so understanding your lifestyle was really important to you. And so did your doctor, your team put this on you? This is what we call shared decision making, right? And a lot of people feel really uncomfortable. Sometimes it may be cultural where you think they went to medical school. I need to ask my doctor's advice and follow what they said to me. In some cases, we can feel empowered and we think, look, I know these choices. I need to choose what's important to me. That's not easy.
It's yeah, and it's not easy, and I can definitely tell you that I am very fortunate and grateful that I am a physician, so I can read these things and kind of weigh my pros and cons for myself as an individual, plus as a patient. And my team, thankfully, has always respected my autonomy. They've always respected the fact that I am a physician, so it has always been a shared decision making move when I interact with them. I know that not all patients have that. And I think that that is unfortunate because it is not supposed to be a power dynamic where the physician is up here and the patient is down here. This is something where, as a patient, you are the expert in your life. What is your expectations, what you need out of the medications, and your physician is the person who is able to say, hey, this is the drug that will probably be the best drug for you, but it has X, Y, and Z side effects. How do these side effects deal with your life? Because there's another drug that we could also try as well. These are the drawbacks, these are the pros, these are the cons. It's kind of that should be the best way to do it versus having sort of an authoritarian, this is the next step.
Yeah, I love that. And it really shows it's so important to get the right fit, right?
Mhm.
Finding that
Yeah,
doctor who will listen to you. So I'm so
right.
glad you have that.
I definitely agree with that.
So in your conversations to prepare for this, what were some of the most challenging side effects you heard of? Which ones surprised you?
So the presentation was linked with ophthalmology and dermatology. So a lot of it was trying to find the dermatological side effects, which I find for instance, for ALK, we don't tend to have a lot of those. The main one would be the photosensitivity, which I know you have a significant photosensitivity. So, in terms of what I found is that when I went to go and talk to like or EGFR colleagues or people who have dealt with like another one of the drugs that just came out, that was when okay, on I'm not going to lie to you. I knew things could get bad, but I saw some stuff that I was like, wow, wow. And as a patient, I was just like, I don't know how I would deal with that. And this is also where this CTCAE versus PROs really come into play. Because, say, for instance, a grade 1 rash is dependent on how much area it covers. But if you have that rash all over your face and now it interferes with you wanting to go out and interact with your peers, your family, your friends, if it interferes with your work, if it interferes with your sleep, is that really just mild? It's very visual with rashes, with skin eruptions and all of those things versus, okay, fatigue. It's fatigue is very subjective,
Yeah.
right? When you know something in theory and concept and then you see it like there's no mistaking it.
Mm.
That was one of the things that this presentation really taught me.
I know. I completely understand that. You're right, because within our ALK community, we are rather fortunate. We don't have some of the really difficult, challenging skin issues. And skin issues almost doesn't feel like the right word because when you see the issues with people's scalp, I have
Mhm.
friends who tell me they cannot towel dry themselves off because how sensitive and how much their skin opens up, the nails, losing them.
But that's so traumatizing. Like, for
Yes.
instance, as a woman with locks, right? Locks are something that is very personal to the person. For me, I've been growing my hair for the past 15 years. It is something that I did through med school, residency. It's a commitment that I did to myself. So to me, it's not just hair. I can't imagine now, being on a medication that is causing not only sores on my head, but because the scalp is so inflamed, my hair is dropping out. And now this thing that's just not necessarily the most comfortable. I don't feel comfortable in my skin. I don't like how I look. So, of course, that's going to make me feel insecure to go out in the world. And these are things that, I mean, yes, okay, it's controlling the cancer, but now I'm dealing with all of these mental health side effects that are just not being addressed and not being taken care of. And then I'm dealing with all of these physical side effects that people try to help, but it's just not helping enough. When I see that, I'm just like, oh my God, that is just
It truly is terrifying, and I often think with all these things and look, I mean, neither one is better or worse because having debilitating fatigue where you cannot get out of your bed and do your job or you're really struggling and the challenge can be that you look normal, and people
exactly.
just think, "But Sydney, look at you. You look perfectly well. You look like your old self. You're just using the cancer card," or I don't know what the accusation might be, right? But it probably isn't nice. But then the flip side of having something that is so visual, right? We are lucky that I often think, well, thank goodness we do have targeted therapies versus having to go on more aggressive chemos where you lose your hair, you look different, you're on the steroids with the swollen faces and all those types of things. And because then people describe the knowing glances you get in the grocery store when you walk in, the kid pickup or whatever it is. It's all hard. It's all
It's
hard.
all hard because then you get the, "Oh, you don't look sick." And then because you don't look sick, people will potentially forget, and then they hold you to a standard of normal that you can't maintain because you're no longer normal. So I think there's always two sides of both sides. So I think that that's one of the things that we all have to struggle with as patients. With us, we are more fortunate to have a lot of things that are not as obvious to the public. A lot of it is internal battling that we can do silently, but we shouldn't do it silently to the point where we're suffering. And I think that that was one of the main points of the presentation. For a lot of us, we try to internally say, well, at least I'm alive. So if I have these side effects, then what do I expect? But at the same time, I think that physicians need to know that just because a patient may look fine when they see you, that doesn't necessarily mean that the treatment is without issues, and you should ask to see and make sure, hey, how are you functioning? How close to your baseline or what you would want to be are you? And then sift what is too much and what is okay. this is kind of a part of the treatment and the cancer. So you're not going to be at 100%. You're not going to run marathons if that's not where you were before cancer.
I remember at one point saying to my oncologist that I was feeling like 80%, and he thought that may be your new normal.
Mhm.
And in a weird way, it was helpful to hear that because I had to manage my own expectations. Will I be restored to 100% of the old me? And I thought, okay, so 80% of the more or less me, I can live with that. Or at least be aware, not be hard on myself sometimes is the other
Exactly.
right.
Exactly. Exactly.
Yeah, I love that. So you were talking also about ophthalmological issues, if I'm saying that correctly.
Yeah.
And
Ophthalmologist. Yeah. Don't worry. I trip over words too.
really, well, thank you. And so for the eye problems, let's call them, what things came up? I mean, maybe I'll share my own. I did find, and it's listed on my medication as a rare, unlikely thing. I felt like I was getting all the side effects, the common ones and the rare ones. And one of the
Really?
ones I did have where I could see stars and floating around. My targeted therapy is known to lead to high blood pressure. My blood pressure normally used to be really low, like 80 over 70 kind of range. And it did shoot up, but to the normal range. So it was 120 over 80. And I remember being told, no, that's normal. But I thought it's not normal for me. Right. And then when it crept up to the high level, it was 165 over 90. The other strange thing that started happening is the blood vessels in my eyes started bursting. Suddenly, every month, about 3 times a month, it would be taking turns flipping from one eye to the next at nighttime, if we're in a car, it looked like someone was high beaming us constantly. And that's how it initially started. And then I would leave one room. And if I went into a slightly darker room, again, it just was these like lightning bolts that would start appearing out of the corner of the eye. And I started getting all these weird investigations. Let's look at a neuro oncology exam. And one doctor, as I was leaving, is like, anything else? I said, well, I keep getting these blood vessels bursting in the eye. And he said to me, how's your blood pressure? And that's what found it. So it was really interesting. We're going down the whole wrong track, and it turned out to be my blood pressure. So anyway, I just wonder from the eye side of side effects, what things did you uncover and see as common in the patient experience?
So the ophthalmology side effects, I didn't get as much reports on, to be honest. A lot of people had a lot more skin complaints. However, I realized in the presentation that Dr. Dalvin did, there were a lot more patients who had some of the newer drugs, the ADCs, the bites, and I haven't really interacted with that many patients who have had those. So I didn't really get that much of those perspectives. I know for me, the first TKI I had flashing lights and I was thankfully warned about it from my provider to be like, hey, you're likely going to get flashing lights. Probably 60% of patients who start on this drug get the flashing lights. They're usually mild. They usually don't last that long. They're probably 1 to 2 minutes, usually after waking up or moving from a dark room to a light room. And if it persists or you find that your vision is changing, then please let us know. And that was also another thing that I brought up in the presentation talking about anticipatory guidance. At least for me, I was told upfront, even before I reported it, this is something that you should expect in terms of eye side effects, what to expect, how long it should last, what the red flags would be, right? It shouldn't interfere with your life, but if it is, please let us know. And by them telling me that, when it did happen, okay, one, I wasn't scared. Two, I knew, okay, it's not something going on with my eyes. Let me run to go to the ophthalmologist and then start down a track and deal with all of these unnecessary tests, right? The fact that I was like, okay, let me start monitoring how long it lasts. Just like what she said, it's supposed to last between 1 and 2 minutes. Let me see if it only comes on when she said it was going to come on. Oh, after waking up, after moving from a dark room. If it's anything outside of that, okay, I need to mentally note that. And she said it should last for a few months and then go away on its own. All right, let me see how long this is lasting. Oh, it went away after a few months. Okay, cool. Certain things are not rocket science. If you let the patient know, one, you told them so they are aware of it. And two, if you give them the background of what to expect and what are red flags, they're going to come to you and be like, okay, you told me X, Y, and Z, but I'm realizing that it's doing now this, right? Is this something that I should worry about? And then now you're really having a good conversation about a possible side effect and how to manage it.
I love that. I think that's so important. And I don't know that everyone has that, right? That help you expect it, predict it, be aware of it. And like you said, then you were able to monitor yourself. And if it lasts for too long or it's more severe than as described, I should report this because I imagine that would also stop unnecessary panics to the team and really be in everyone's interest to just help provide that guidance.
Yeah. Yeah. And one of the things that it really also taught me is that, like, having these specialists integrated, or what we described as toxicology boards, just like you have the tumor board, having a tox board in terms of with these more normal side effects, having specialists that are able to help out or integrate earlier, that is something that really would be beneficial. So when you know you're going to put patients on this drug, that 70% of patients who go on the drug end up having skin conditions, 70% may not be all percent, but if that patient is the patient that fits into the 70%, they're 100%. So it's kind of like, how do we say, okay, we're going to put this patient on this drug, right? They have a high likelihood to getting these side effects. Okay, having this person on board or kind of in the wings to be like, hey, I'm going to put a patient on a treatment. If I need you, I'm going to send a patient to you. Having that person that you know already set up means that when the patient does start having those symptoms earlier, you can say, all right, let's switch you to see this person so that that person can help mitigate and slow down these side effects.
And I don't think that it obviously happens enough. And part of me, I just think if patients don't have this kind of physician that's helping them to anticipate, maybe it's also about us as patients coming in, what side effects should I expect? Prompting those questions. Don't just wait to be told. And there might be something we can help patients in being more prepared.
Yeah, I tell patients this all the time. You see, I'm a hospitalist, so I see patients only when they come into the hospital, and then we stabilize them and then they leave. So there's not much of a relationship with that person once they leave the hospital. But one of the things I always tell them is you're going to interact with many different doctors, right? Thankfully, oncology is one where you usually have a relationship with that doctor and that doctor then knows you. But also remember that doctor has a gazillion patients, right? So they can't remember every nitty gritty detail of your file. You can remember every nitty gritty detail of your file. So you need to be the best reporter possible, right? You need to be able to ask certain questions. You know what's important to you. For instance, you talk about your medication causing hypertension. I have been running away from hypertension for a very long time because my mother's side of the family, my sister got hypertension at 32,
Oh my
right?
goodness.
It's a very strong family history. And for me, at a very young age, I was like, nah, I don't want to deal with that because they have very resistant hypertension, taking 3, 4 drugs. And I was like, I didn't want to deal with that.
Right.
So, of course, you give me a medication, I'm going to look, oh, the side effect is hypertension. No, I don't want it because I will definitely get it, right? Because I already have a strong propensity for it. So
Yes.
it's kind of like stuff like that as well.
No, but that's so important, the familial history, right? I mean, that is so true, and a lot of these things, whether it's cholesterol, there can be heart risk associated with some of these
Mhm.
medications, so you have a familial history as well. It's not just what's happening in your life, it's like, what are you at risk for? So, I love that. That's great advice. I wonder if you have, maybe in closing, what would your advice be to physicians, and what would your advice be to patients, since in a way, this talk is directed to both?
So, my advice to physicians would be, instead of asking, is it mild, moderate, and severe? You ask, how is this symptom and how is it interfering with your life? You can ask mild, moderate, or severe, but I think that mild, moderate, or severe is so subjective. But how it interferes with someone's life is not as subjective. It really does show you this is something that is a little bit more troublesome. Let's see what we can do to tweak this side effect. Some of them you can't. And You need to acknowledge when you can do something or when you can't do something. But I think that acknowledging a side effect and how it could be interfering with a patient's life is a good first step. When it comes to the patients, I think a lot of the times we don't want to bother the oncologist. We feel like they're very busy. We're afraid of that's nothing. There are a lot of symptoms that, because physicians have seen it over and over again, we know what is not serious versus what is serious. As for instance, what you're saying, if you got those burst vessels every once or twice, yeah, that it's alarming to look at, but it's not really that serious. But as you said, if you're getting it over and over and over again, it's basically a symptom that's pointing to something else because it's not normal for you. And you, as the patient, are the expert in what is normal for you. Your physician will never be that. So you need to also insist, right? Even if you feel like you're dismissed, insist when something is not normal for you. If your physician is not listening, even with you insisting, then it's time to get someone else because you need to have the type of relationship with your provider that it can be shared decision making. They can listen to you as much as you listen to them. And I think that that's the best way that you will be able to survive is if you have that type of relationship with your oncologist.
I love all this. I think so many great pieces of advice. And so thank you so much for sharing with us, Sydney. Thank you for joining us and congratulations on this exciting talk and important topic for all of us. So thank you.
Thank you. Thank you so much, Yvonne.